Bismillahirrahmanirrahim. Our topic today is about osteoporosis. Our agenda include definition, pathophysiology, types and risk factors, clinical presentation, investigation, diagnosis and treatment of osteoporosis. Osteoporosis means porous bone. It is a skeletal disorder that is characterized by reduction of bone density leading to bone fragility and increased risk of fractures. Osteoporosis is the most common metabolic bone disorder. Pathophysiology of osteoporosis. Bone remodeling or turnover is a process that involves old bone resorption by osteoclasts and then new bone tissue formation by osteoclasts. This mainly occurs in the adult skeleton in order to maintain bone integrity and mass. Bone remodeling is affected by factors like hormones, parathyroid hormone, calcitonin, sex hormones, growth factors, physical activity, and nutritional factors. Osteoporosis results from imbalance between bone formation and resorption due to increased bone breakdown by osteoclasts or decreased bone formation by osteoblasts. Types and risk factors of osteoporosis. There are two types of osteoporosis, with either primary, postmenopausal and senile, secondary due to diseases or medications. Type 1 or postmenopausal osteoporosis occurs predominantly in females about 10 to 15 years post-menopause due to decreased level of estrogen. Type 2 or senile osteoporosis affects both male and females after the age of 70 due to nutritional factors and decreased physical activity. Secondary osteoporosis affects both male and females at any age as a result of disease process or medical treatment. Medical risk factors for secondary osteoporosis include lifestyle conditions like embolization, excessive thinning, smoking, endocrinal disorders like Cushing, hyperparathyroidism, thyrotoxicosis, hypogonadism, type 1 diabetes mellitus, deficiency state like vitamin D and protein deficiency, GIT disorders like malabsorption, cirrhosis and inflammatory bowel diseases, rheumatological disorders like rheumatoid arthritis and ankylosing spondylitis, renal osteodystrophy, chronic obstructive pulmonary diseases, hematological disorders like myeloma, lymphoma, leukemia, hemophilia, sickle cell disease and thalassemia, genetic factors like osteogenesis imperfecta and Marfan syndrome. Medications predisposing to secondary osteoporosis include hormonal factors like glucocorticoids, corticotropin, L-thyroxine aromatase inhibitors, and progesterone, hypoglycemic or antidiabetic drugs like thiazolidinediones, CNS acting drugs like antiepileptics, antipsychotics, and selective serotonin reuptake inhibitors, chemotherapeutic and transplant drugs like methotrexate and cyclosporine, anticoagulants like long-acting heparin, proton pump inhibitors and aluminum containing antacids, and antiretroviral drugs. Clinical presentation of osteoporosis. Clinical evaluation of osteoporosis include history of predisposing conditions, drugs, fractures, which often occur with minimal trauma. Osteoporosis may be asymptomatic. Pain may occur due to fractures, for example, point tenderness over vertebrae and other suspected fracture site. Dorsal kyphosis, loss of height, are deformities that occur due to osteoporosis. Also, there may be signs of suggestive of secondary osteoporosis, like signs of thyrotoxicosis or Cushing syndrome. Investigations and diagnosis. Laboratory investigations. Laboratory indices are not measured in osteoporosis. Lab investigations are useful in excluding or identifying secondary causes of osteoporosis. These include calcium phosphate, alkaline phosphatase, biochemical markers of bone turnover, additional investigations according to the suspected cause like CBC, liver function, TSH, parathyroid hormone, cortisol 25-hydroxy, vitamin D. Radiological investigations for osteoporosis include conventional X-ray and DEXA. Conventional X-ray may show cortical thinning, increased radiolucency, fractures, for example vertebral compression fracture. Dual energy X-ray absorptiometry or DEXA scan is a gold standard test for bone mineral density and for evaluation of future fracture risk. DEXA scan is used to calculate bone mineral density at lumbar spine, hip, and proximal femur. Bone mineral density measurement is recommended for women over 65 and men over 70 regardless the risk factor. Individuals with fragility fracture, individuals with conditions that predispose to secondary bone loss before therapy, and for monitoring of osteoporosis pharmacotherapy. Bone density data from DEXA are reported either as T-score or Z-score. T-score is the patient bone mineral density value compared to that of young healthy adult. WHO definitions include normal bone mineral density value within 1 standard deviation of the mean level for a young healthy adult. T-score at -1 and above. Osteopenia or low bone mass is bone mineral density between 1 and 2.5 standard deviation below that of the mean level for a healthy young adult. T-score between -1 and -2.5 standard deviation. Osteoporosis is defined as bone mineral density of 2.5 or more below that of the mean level for a young healthy adult. T-score is equal to or less than -2.5. Severe osteoporosis, bone mineral density 2.5 or more below that of the mean level for a young healthy adult with fragility fracture. T-score is equal to or less than -2.5 plus fragility fracture. Z-score compare bone mineral density with that of age, sex, and ethnicity matched adult reference value. It is used for premenopausal women, men less than 50 years of age, and in children. Z-score more than -2 standard deviation is defined as within the expected range for age, while Z-score value of equal to or less than -2 standard deviation is defined below the expected range of age. Treatment of osteoporosis. Non-drug therapy include treatment of any underlying condition, for example hyperthyroidism. Avoid or modify drugs that induce osteoporosis. Lifestyle modifications as weight-bearing exercise, stop smoking, increase calcium in diet, fall prevention, and orthopedic fracture management. Bisphosphonates are the most widely used first-line drug for treatment of osteoporosis. Bisphosphonates are potent inhibitors of osteoclast activity. Oral forms include alendronate, risedronate, abendronate. Intravenous form is zoledronic acid. Absorption of oral bisphosphonate is affected by food and beverages, so it should be taken alone on empty stomach first thing in the morning with adequate amount of water. Oral bisphosphonate should not be used in patients with active upper GI diseases or inability to remain upright for 30 to 60 minutes, in esophageal stricture, vitamin D deficiency, hypocalcemia, hypersensitivity to drug, and in renal impairment. Short-term use may be complicated by intolerance, erosive esophagitis, and gastritis. Osteonecrosis of the mandible rarely complicate long-term use. Intravenous administration of bisphosphonate causes acute face reaction like fever, bone muscle ache with the first dose. Hormone replacement therapy. Hormone replacement therapy is not currently recommended for treatment of osteoporosis. However, it can be used in premenopausal women with estrogen deficiency to prevent osteoporosis, and in postmenopausal women in whom non-estrogen medications are not considered to be appropriate, when benefit exceeds the risk. Mechanism of action: estrogen suppress bone resorption by inhibiting osteoclasts. Adverse effect: increase in the incidence of breast and endometrial cancer, increased risk of deep vein thrombosis. Selective estrogen receptor modulators, raloxifene. It inhibits the effect of parathyroid hormone on osteoclasts. It has no trophic effect on breast or uterus. It is contraindicated in fertile women. However, it may worsen hot flushes and increase the risk of thromboembolic diseases. Androgen can be given for hypogonadal men to treat or prevent osteoporosis. Calcitonin is a hormone that decreases osteoclast activity, thereby it slows bone loss. It is available as nasal spray and injection. Not used as the first line because more effective drugs are available. However, it remains an option for patients who are not candidate for other available osteoporosis treatments. Side effect: common side effect of nasally administered calcitonin include nasal discomfort, rhinitis, nausea, local inflammatory reaction at injection site, sweating, flushing are side effects noted with parenteral use. Denosumab is a human monoclonal antibody against rancor, so it inhibits osteoclasts, available as in an injectable pen, used in the treatment of patients who are at high risk of fracture, patients having a history of osteoporotic fractures, or patients who have failed or are intolerant to other available osteoporosis therapies. Hypocalcemia must be corrected before therapy. Side effects include serious infections, dermatitis, rash, and eczema. Recombinant human parathyroid hormone peptide, teriparatide. It stimulates bone formation. It is available as an injectable pen. It is indicated in patients who are at high risk of fracture, patients having osteoporotic fracture, and those who have failed or are intolerant to previous osteoporosis therapies. Side effects include dizziness and leg cramps. It is contraindicated in patients at increased risk of osteosarcoma and those with open epiphysis, prior radiation, bone metastasis, or untreated hyperparathyroidism. Supplementation with calcium and vitamin D. In postmenopausal women with osteoporosis, 1,200 mg of calcium daily and 800 international units of vitamin D daily are advised. In premenopausal women or in men with osteoporosis, 1,000 mg of calcium and 600 units of vitamin D daily are generally suggested. Ideally, serum 25-hydroxy vitamin D should be measured in patients who are at risk of vitamin D deficiency, and then vitamin D supplement can be used to bring serum 25-hydroxy vitamin D level to approximately 30 nanogram per milli. Thank you.